Is this on? It is, good. So welcome back. So our first speaker this afternoon is Professor Stephen Williams, and he is the head of the Neuroimaging Department and Professor of Imaging Sciences at King's College London. He's also the founder and director of the Centre for Neuroimaging Sciences based at the Institute of Psychiatry in Maudsley Hospital. And Professor Williams has strong interest in the translation of brain imaging techniques from the bench to the clinic, and his talk this afternoon will focus on the topic of imaging in psychiatry. Welcome.
Thank you, Jo, and welcome back, everyone, refreshed from a lovely lunch. And thank you very much, Joanna and everyone, for the invitation. And that incredibly envious presentation just before lunch of all the facilities that you have available to you. So if you're not an imager and you want to go and see Joanna and colleagues about imaging in Edinburgh, they've got no excuses. Having seen all that kit that you have at your disposal, well, that's absolutely fantastic. So I'm going to talk about imaging in psychiatry, and I'm going to focus on MR in particular. And in my half an hour, why am I going to focus on MR? Well, MR, as a few of the speakers said this morning, has had more makeovers than Madonna. Every year, there's a new modality that comes along, a new tweak of the technology that allows us to go from looking at structure to chemistry, to function, physiology, perfusion, wiring, myelination, maturation, networks, etc. And I'm just going to take through some of the applications that we're working on, not as a field, in psychiatry, where these might have a clinical utility one day. But at the same time as all of that end use and sort of drive for novel applications, there seems to be a renaissance from the engineering side as to what we should and could be doing in MR. And I've focused a bit more on this in the last few years. We have a medical engineering centre down at King's in London. And that's definitely become something we're really putting an effort into for the first time, being much more patient-centric about where our imaging is going. So Steve Jobs, he said there's no rocket science to design and innovation. It's all about working back from the customer experience. So in our case, it's a patient lying inside a scanner, or in my case, it's the Williams family, whether it's a seven-month-old niece or a 7-year-old daughter or a 47-year-old wife or a 70-year-old mother. And I'll take you through, during the next half an hour, some earache I've had and some of the things I'm trying to help to do to address some of the concerns they have. My son had a scan. He was a control for an autism study. He said, "Dad, I'm struggling to lie still." So I said, okay, we'll work on scans that allow us to make an image that's still diagnostically useful even when someone is moving. So on the left-hand side, you build up a sort of image line by line by line. It's that classic raster scan image. But now the whole field, and the MR physicists like Jim Pipe in the US, have come up with these really clever methods which allow us to, maybe see if I can get this working, which allow us to build up an image line by line or propeller blade by propeller blade, and you have a common reference point in the middle, so that if you do move, then you know where you should have been in the middle of that trajectory, so you can correct the scan. And so the person here was moving just as much, my son on the right, as he was on the left, but now I can get something that's diagnostically useful. So that can be really beneficial in psychiatry and neurology, because so often we're working in research. I'll have loads of dirty secrets that are going to come out of the next half an hour. Working in research, you say, oh, we're going to look at a certain disease. Well, we're not going to look at the extreme cases. We're not going to look at that autistic kid that's not going to lie still. We're not going to look at that person that's hypersensitive to sound. We're not going to take our most technophobic and most demented dementia patient. But those are exactly the ones that we should be looking at. The most extreme cases of pathology and biology are the ones we're going to learn most from. So we've got to think about the imaging modalities that we're using that can be, that can accommodate that limitation of that patient that we're looking at. So that allows you to perhaps look at the same patient over 2 years when they really are severely ill at the end of their dementia time course and get some information about from the in biology. My mum, she had a minor TIA, a transient ischemic attack, a few years ago. She was sort of fine about it. She was quite sort of looking forward to going into one of her baby boy's scanners until she was being wheeled in. She went, whoa, 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 why are you going all the way in as far as my ankles to be able to look at my head? And there is truth in that. So why, when 35% of all MRIs done in the world are of the head, 65 to 70% of all 3 Tesla MRIs are over the head. 96% of all 7 Tesla MRIs are over the head. Are we still making whole body machines? So we have to start thinking about making machines that might be more appropriate for subjects. And the GE chief exec said to me, Steve, give me an emotive reason why we should be making them. I said, I want to be able to hold my child's hand when they're having a scan. And he went, okay, that might be good enough reason. My mum also said, I've got a bad back. Why are you making me lie down inside one of these machines when I'm having an MRI? So she said, why can't I have a scan like I used to go to my hair salon with all my girls and have a chat? Why can't I have that? Well, it's not beyond the realms of possibility to do it. So I'm talking to Oxford Instruments at the moment. The people have made the first ever MRI magnet in the world about taking their NMR spectrometers, which is what I did for a PhD at Cambridge 30 years ago, and just making head-only MRIs that you can sit inside. That would then allow us to do eating, drinking, typing, driving studies, studies of vestibular function, studies of stroke patients who can't lie down flat, people with motor neuron disease that are struggling to breathe, vegetative state, you name it. There are so many conditions that you would now be able to look at the brain which are not currently feasible. If you're a pharma company and you're making a new drug, you'd love to see whether that drug's getting in the brain early on, but you'd be worried about nausea when you're doing a first phase study. If you're sitting up, it's less of an issue. So watch this space. I think that might happen. Siemens and others have made head-only machines years ago, but there's a renaissance now, and GE are actually trying to make a 3 Tesla, and the first one's gone into the Mayo, and the images are looking really promising. I mean, for the end users here, these scanners are going to be much smaller, lighter, go into a large office. There's going to be very low, if no helium boil-off. It's going to be 1 to 2 tons. It should be a lot cheaper in the long term as well. So that's something to keep in mind. And you know, you could sell it as a dementia scanner, you could sell it as a stroke scanner, you could sell it as a baby scanner. So yeah, depending on the market, that's the way to go with these things. My daughter had a scan as a control for an ADHD/OCD study. So she went on the scanner, was very happy with it all. But the first thing she said, it's far too noisy. So there's a real move in the field at the moment with this. Oh, is this going to work? Please work. It's not working. Go on, sir, go on. I've got to make you hear this. So there are now numerous groups around the world. One of them is a lady called Annabella Solano, who did a PhD with us, and now she's doing a postdoc at GE in Munich. And that is a functional MRI multi-echo. So now you can start thinking about doing baby resting fMRI studies, sleep studies, auditory hallucination studies, language studies, things that might have been a challenge in the past. So the technology is called Rufus. If you have a PET MR machine that's doing 0 TE images for your attenuation correction of your PET data, then you're pretty much there. You'll be able to do this. It's a tweak of the technology to be able to do this. It's not something that's exclusive to GE. It's a really exciting technology. We have this now running not routinely. We have it working well in our structural MRI. We can get nice 1 millimeter isotropic images in a few minutes with a silent structural MRI. And I think cracking the multi-echo fMRI with a comparable temporal resolution was something I was not expecting. But Looping Star is the adaptation of that methodology that Anna Bayer has done. It's a very exciting time. But back to the day job. My day job is trying to, when I have a meal with friends and colleagues, we just say, why are you bothering looking inside the brain of these mad people? It's all in the mind. You're never going to see any biological difference. So that we spend a lot of time going back through the literature and doing meta-analyses. Take, for example, dementia. There'll be thousands of subjects in these 15 studies we mentioned here. If you look at the meta-analyses, normal is 0. You get a dramatically smaller hippocampus left and right in that cohort. We knew that already. We showed a slide about that earlier on. But you use the same technology, something as simple as a quick structural scan, draw those hippocampal volumes and look for something like PTSD, which was mentioned earlier today. There is a dramatically smaller hippocampus in PTSD, shell shock, Gulf War syndrome, whatever you want to call it. and we don't know why. Is it that their brains are smaller, the hippocampi are smaller to start with, so they're more vulnerable? Or is this as a consequence of the trauma? That still needs to be determined, and it's something we really want to look into. 5% of all soldiers coming back from the theatre of war in the Middle East have PTSD. It's almost 10% of American forces. Why the disparity? We don't know. I know there's a few Americans in the audience. We think it could be IQ. There's a slightly lower IQ in the American soldiers, which means they may not be able to cope as well. But the other reason, which I think sounds a bit cooler and probably more realistic, is that Americans don't drink on tour, but the Brits, when they've had a bad day in the office, they get absolutely plastered that night. And they may not be actually putting down the memories in the same way. Whereas the Americans smoke spliffs like nobody's business. So that THC could be really bad. So that's something that we're really looking into. Depression. Well, if you're a GP and you've been presented with someone with a mood disorder for the first time, wouldn't it be great if you could tell whether they had major depression and you could put them on Prozac or talking therapy, or whether they was bipolar, and then you would put them on something like lithium. If you put these onto Prozac, then you could make things a lot worse and exacerbate a manic attack. So if you could develop some sort of quick 5-minute biomarker that discriminates those two, that could really inform their management in the same way that personalized medicine, or now we're calling precision psychiatry, is starting to take off. Not there yet, but that's not beyond the wit of man. To take all this fantastic work that's been done with things like ADNI for dementia and bringing it now into disorders like depression, which is again is another huge consequence. But it's not just the hippocampus that's smaller in a disorder like schizophrenia. We know the ventricles are bigger, there's some deep grey matter changes which might be medication related. So we need to be thinking about the whole brain and not just one bit. So how are we going to do it? Well, you're doing this every day in your lives. If you look at those two pictures, you can tell one of them is a famous actress. Now, I'm not going to tell you which one's which, but you can work it out for yourselves. If you look at any one feature, just the hair or just the earrings, then you might not be able to tell. But once you look at all of the elements of that image, you can actually determine which one is which. And that's exactly what we're now trying to do with computers. We're developing these machine learning algorithms, bringing all this technology from Google and Facebook and the like into digital healthcare. How does it work? Very simply, you take your brain scans that have been expertly labeled. These could be controls, and these could be our patients. And then you run the machine learning algorithms, develop a discrimination map so that when someone that comes along that hasn't been diagnosed yet is benchmarked against this database, you can get some prediction of whether they are a patient or not, or whether they're going to respond to treatment or not. And that is a hell of a lot of work. Very exciting and very promising going on in this area. This is just one of our examples. This is adults with clear-cut autism versus age, IQ-matched healthy male controls. From the quick 5-minute structural MRI, cortical thickness measures, you could classify and distinguish those groups with over 90% accuracy. So that's really exciting, quick potential triage tool, but also pointing us at the underlying biological differences between those groups as well. More real-world application, I think that's going to really take off, and this is from the Oxford group a couple of years ago now. They bundled together a bunch of modalities. They took a structural MRI, another type of MRI. In isolation, they're only about 60 or 70%, but those two in combination with the CSF measure of amyloid, you could tell who was going to get Alzheimer's 2 years before they've got it, with over 90% accuracy. You may not want to know, but if you do want to know, then it might be you would volunteer yourself for those trials. So you can enrich the sample for the types of trials that people are now doing in dementia research. So you have less outliers, etc. So that sort of predictive or prognostic sort of tool is becoming quite widespread. We are looking at 1,000 males in their late teens and early 20s, who have a first-degree relative who has a mental health issue, typically a psychosis. And then they'll have grown up and they'll have had school records which are looking a bit unusual, and they're starting to express these soft signs, which are called the at-risk mental state. Now, within about 18 months to 2 years, 15% of those will transition now their first psychotic event. And what you'd like to do is to, of course, treat those people with the psychosis, but give some sort of prophylactic intervention to that subgroup that you know are going to transition. You don't want to give these nasty antipsychotics to everyone because they've got some terrible side effects like weight gain and movement disorders. But wouldn't it be great if you could actually tell from the brain scan or from the biology, from the genetics or a combination thereof, who might transition? Then you could treat those before the first psychotic event and maybe delay or defer it for a very long time. Just as with an epilepsy, the more psychotic events or more events that you have, the worse the brain gets. So we really want to get in there early. So this is part of a major program of research now across Europe and Australia, where we're pooling thousands of subjects to see, is there something that might be predictive? Initial studies from Germany, from Nikos Koutsaris and colleagues, look really promising. Again, scanned on several occasions and see, is there something about that initial brain scan that might be predictive of that red group there, that transition? I'm going away from psychiatry for 1 minute. You can do multi-class, multimodal. So you might take a whole series of different imaging modalities alongside your genetics and clinical information, and you might have many different classes. So these are all Parkinson's, or these are subjects that present at a movement disorders clinic at King's, and at initial presentation, the neurologist doesn't know whether it's idiopathic Parkinson's or one of these much more aggressive PD plus syndromes like multiple system atrophy or PSP, which is what Dudley Moore had. Or when you ask them, how do you discriminate? They said, well, normally you have to wait 6 months to a year, and these groups decline much more rapidly than this one. So could we do a scan at initial presentation that discriminates between those three groups, which could really impact on their clinical management of these three? And again, in preliminary results, groups of 20 or 30, but looking really, really promising just from the structural MRI. So that machine learning stuff we've put bundled together, and we've now made it available, and it's open source and everyone can access and play with it, and we've applied this now to a range of disorders, pain, schizophrenia, and social anxiety, where we did an online intervention for those poor mice that were getting a cat on the top of the cage. So, you know, this is the sort of thing that one can do. But this is me. This is a typical situation of someone like, well, I do this all the time. I book a subject for the scan, and I book it for an hour. Really, they may only need 5 or 10 minutes because we want to run a diffusion, and while they're there, we'll do a perfusion, or let's do this new quantitative method as well. So what the technology and the machine learning allows us to do is it's agnostic. It tells you which one or combination of measures is really important for helping to distinguish or classify that subject from the rest. That's where we're going with it all. But what we're going to do, I mean, when you go inside a scanner, you have one person might have one type of scan, the next person you give them another type of MRI. Let's at least standardize the way that we do our structural MRI. And we are trying to do this. We're trying to develop what we call a scan for all seasons. A scan that will work on all the major manufacturers, GE, Siemens and Philips, and it allows us to synthesize the images after. So this is from a structural scan, it's from a structural MRI, on a scanner, and the radiologist can then dial, having made that one scan, they can dial the TE and the TR and the TI to be able to optimize the image for the bits of the brain they want to look at. I was driven to help develop this by frustration in psychiatry, where 1 week Simon Baron-Cohen, the world-leading expert on autism, came to me and said, we need to optimize the imaging for the amygdala. 2 weeks later, he said, it sounds like the cerebellum is where we should be going. And then a month later, it was the frontal cortex. And now he says, well, it's the whole brain. And you'll have optimized the scan for one type or the other. So we needed something that allows us to revisit and future-proof the imaging data that we get, so that you can go back and synthesize the scan that you want in any arbitrary orientation. So instead of collecting that type of scan, then this one, then another, you can get the whole protocol in less than 10 minutes and go back and synthesize the data. I've taken some slides up, but very simply for the MR physicists in the room, it's a gradient recalled echo, second gradient recalled echo image. All you do is tweak the tip angle between the two images, which gives you your T1 map. Then you do a pair of SSFP images, and they're called fast field echo on one machine, and they're called Fiesta on another. And you, again, fix all the parameters and change the tip angle just slightly, and that pair of images gives you the T1 and T2. So from that combination of the 4 scans, you can derive a T1 map, T2 map, and then synthesize any image you want. So that's being rolled out more and more for our work. You also, from this data, because it's quantitative and it gives you relaxometry, you can tease out the myelin water fraction, that really short relaxation component of the water signal in the MRI. Optimize that all in your animal scanner in a mouse, take it into a neurological condition where you know there's a positive control, which is MS, compare it with the gold standard, which is flare. So we're seeing dramatically greater myelin loss in this type of myelin water fraction image relative to flare. Having got it working in the brain, it works equally as well in the spine. You see myelin water fraction differences there that you don't see in a conventional MRI. And why are psychiatrists interested in it? Well, because we want to go full circle and bring it back into baby brain development, because lots of psychiatric disorders like autism, schizophrenia, and ADHD are neurodevelopmental in origin. They might start very early in life. So we're looking at myelin maturation over the first year. So as you're born, your brainstem and your cerebellum is mature enough so you can breathe for yourself. As you start to use your fingers, your corticospinal tract's mature. And the very last part of the brain to mature is the frontal cortex. So we're looking at this in healthy subjects, and we're looking at it in boys whose older brother has been diagnosed with autism, because the younger brother's got a 1 in 4 chance of also having autism. So can we pick up a developmental delay in our silent, quantitative MRI scan? And how do we go full circle? Well, we're doing some animal work that goes alongside, and I sneaked this in the last minute because of the Rosalind affiliation here. We're doing some work in baby pig brain as well, and this is a young baby pig at 3 weeks old on our 9.4, admittedly Birken hair, this is ex vivo, but you can get these beautiful images in a matter of tens of minutes at high resolution on the high field, which maps onto the histology and back into the in vivo. And we're trying to do those bridging studies more and more, and I know you're doing those here. But one day, we might be even diagnosing psychiatric disorders in utero. Rather scary, isn't it? So this is Joe Haenel and David Edwards and colleagues at St. Thomas's doing this work. They've taken those motion-insensitive methodologies, applying them to imaging the baby in the womb with a strong focus, of course, on things like fetal growth restriction and poor placental blood flow at the moment. But one day you could imagine applying the same ideas and concepts to neurological and psychiatric conditions, keeping in mind the ethical implications therein at this stage. Okay, my last few minutes. One technology that's really taken off in psychiatry in the last few years is this arterial spin labeling. So I'm sure nearly everybody in the room knows about this technology, but as a simple diagram of that, how does it work? Subject's lying inside the scanner, you've done your MRI, now we're going to apply some radio frequency to the neck, we're going to somehow label or magnetize or tag those spins, and we're going to image upstream from where we labeled. You make one image with the label on, one image with the label off, and the difference between the two is a really nice high resolution CBF map, a couple of millimeters resolution, without some of the signal dropout that you have in many of your functional MRI scans done with EPI, because the readout for this is a fast spin echo. And we're using this in a whole host of conditions. Let's say, for example, drug development. Can we see the main effect of a drug in the brain? They come along on one occasion and have placebo. They come along on a second occasion and have, in this case, a drug used to treat schizophrenia. And you can compare the images on the CBF maps from the 2 visits, and you see those areas of significant difference in localized perfusion on the drug. So this could inform what's the right dose, and what's the half-life, and what's the time that the drug has a maximum effect functionally in the brain, to complement what might be done with a PET. So if you have a PET MR machine and able to do these 2 things simultaneously, that's just going to be amazing. You can see when the drug's hitting the receptor and the PET, and you can see the downstream effect on function using this type of technology, the perfusion MRI. So that when you're a company like Lilly, who is trying to develop a new drug to treat attention deficit, they want a drug that gets in the brain, they want to know what's the right concentration, but they don't want a drug that's exactly the same as Ritalin, methylphenidate. If it's exactly the same as Ritalin, why bother making it? Because we want to target those subjects that are not responding to this drug. And of course, this drug's now off patent, it's generic, there's no money in it. So atomoxetine, or Strattera, as it's now known, we show that it does get in the brain, it does modulate bits of area in blue that are not the same, and that can inform potential indications for the drug as well. It's not unheard of us doing this type of study where someone walks in with a cognitive enhancer and then they walk out with an analgesic, because you get some insight about exactly which bits of the brain that the drug is hitting. How long have I got with Miss Jill? Have I got a few minutes? 7 minutes. Oh, right. Thank you very much. I can slow down. Now I have my City-Uppy vertical MRI machine. I can do all those intranasal studies that no one can do at the moment. So people are developing insulin to treat dementia. Ketamine is a drug to potentially treat depression. Oxytocin is the love hormone. As you hug someone, you release oxytocin. And that's being developed at the moment for schizophrenia and autism. People didn't think it got into the brain or had any effect on the brain. So we did those perfusion studies with intranasal oxytocin. Of course, we had to move them out and sit them up, and they had to sniff it. But it would be lovely to do it sitting up, so with a vertical scanner. And you can see where there's a central effect, that window of opportunity where you have about 45 minutes to an hour where that intranasal oxytocin is having a central change in perfusion. Showed this to the psychiatrists, they're quite excited. But I showed it to the psychologists and they went bonkers. They went, do you realize this opens up a window for social cognition when we are actually treating our schizophrenic patients or our autistic patients? We can get them to sniff this while they're having their talking therapy, and layering this on top might really impact on the speed and efficacy of their treatment. So early days, but again, exciting potential there. I mentioned earlier, and you have these machines here with Ian and Moritz, and people that are running them. These machines, as I say, this is what makes MR and PET and these imaging methods so beneficial to the society in all of our work, whether it's in industry or in academia or in hospitals. We can translate the science from the rodent, the mouse, to man. And this is an example of where we did that. So ketamine, or Special K, as it's known in the Brixton nightclubs, Special K at low doses causes a slight cognitive impairment and a psychomimetic-like state. So it's used as an experimental medicine model for schizophrenia. So we did all the optimization in the rat, and we could see those bits of the brain that had a central effect on ketamine. And you could do exactly the same scan on the subject and see those bits of the brain that changed as well. The idea being that now, having shown the model working well, we pre-dose this subject with antipsychotics to block that effect. And we've now in late stage development of some new antipsychotics using this as an experimental medicine model. Again, not using the dopaminergic system. So we're trying to get away from dopamine antagonists for this treatment of schizophrenia, and it's looking very exciting. The biggest challenge, without doubt, in psychiatry is to develop a drug to treat cognitive impairment. If we could get a drug to improve cognition, then you would have an impact across all of these different psychiatric disorders. This was a study done by Mike Davison and colleagues now over 10 years ago, where they looked at 100,000 patient notes, subject notes from the Israeli army conscripts. They asked the question, what is it about these people at initial evaluation that might have put them at risk of developing one of these psychiatric disorders many years later? And it was poor cognition to start with. So if we could develop some sort of intervention to improve cognition, that could really have a massive effect on psychiatry. So the pharma industries and the neuroscientists are now taking iPads and putting them on the end of rat cages and getting rats to do these discrimination tasks, and then they're being rewarded as they run to the back of the cage when they get the order right. And of course what we do is we're doing the same thing in the scanner with our healthy subjects. So we can get them to do exactly these type of Cantab batteries, where they see something on the screen, it goes away, and a few seconds later 4 choices appear, and we then are able to get the functional neuroanatomy of them doing that task. So if you've got a rat that's performed well on this task here, you can take it into the scanner, and then you get some insight about the functional neuroanatomy and the network that can be modulated by the drug. I'm not saying that every element of drug development needs to have the MRI scan, but this type of information and an atlas like this could help inform which drugs you take forward into the latter stages as well. Or the most classic one is the Morris water maze, where your mouse is trained to swim across a milky pond onto a platform, and then after doing this for a few days, then you submerge the platform, and they then still find their way back to where the platform was, because they've got all the cues around the laboratory, all the visual cues. You can do things like add scopolamine to impair it, or lesion the hippocampus, and it goes away. So how are we going to get a mouse to do this inside a scanner in a watery pond? Well, you ain't, but you can get us to do it. So we go inside a scanner doing the human equivalent of the Morris water maze. So if you can do something as mad as this, any sort of paradigm's viable. So here's our subject, lie inside the scanner. He's going to be looking back out. He's got a joystick. He's going to be looking at a screen, and there he is. He's walking towards that platform, taking in this abstract mural behind. This is what we're seeing from inside the scanner room. So we're imaging away as he's walking towards that podium. And a few minutes later, having done the task, we put him back in the virtual room in the absence of that platform. I let it play through for a few seconds. So the idea being that we can build an fMRI map, we can build the functional map of the human brain while they're encoding, while they're laying down the memory, and a second series of scans while they're retrieving and trying to remember where they were in the room. So that can, again, inform the development of novel medications. And you can tease apart which part of the memory process the drug is having an action. Ideally both, but it might be just one or the other, and that would be good to know as well. And you can tease out the maps from the encoding and the retrieval phase. Dirty secret there again, I know we don't smoke anymore, but nicotine works incredibly well on these paradigms. Maybe nicotine patches or nicotinic agonists should be where we go forward. Very last slide, 2 slides. Where could we use functional MRI, which I've hardly mentioned, in psychiatry? Well, this is a task that we did many years ago, which looks very promising. So see if you're all still awake. I mean, this is the paradigm you'll be doing inside the scanner. I'm going to ask you all, can you tell me, hands up if you think that face is a female? A few people think it's a female. How many people think it's a male? Okay, a few people think it's actually a female. Now, that's the paradigm you do inside the scanner. But what we're making you do is actually attend to the face and look at the facial expression. So as you see one picture, then you see the next, and then you see the next. And what happens with the depressed patient, they over-empathize with this. They perceive that as negative, and they really do almost catastrophize when they see a very sad face. So you get a brain scan that's completely different from the depressed patient, from the healthy volunteer, and then you can discriminate with your machine learning between those two groups. You get your fantastic paper in a great journal, and then somebody says, yeah, but I can just ask someone if they're depressed or not. Why do I need a £500 scan and some machine learning to do it? I mean, yeah, you're right, let's think of something that useful that we can do with it. Well, all those circles which were the patients, they all then went on to fluoxetine, Prozac. They were all drug naive before, and typical in psychiatry, at best, 50-60% will respond to treatment, which they did in this case, and at best, every psychiatric disorder is chronic, the intervention is long-term. You wouldn't know for 1 to 2 months whether they're actually responding or not to the drug. But from the baseline scan, before they started drug treatment, we could predict an accuracy of over 80% who was going to respond or not. So there's something about the amygdala activation and the connectivity that was working there. Is it just a one-hit pony? Well, we did another experiment with another group of depressed patients. This time the intervention was a talking therapy, which is 16 weeks, once a week, very expensive, 16 weeks. Again, the same outcome, maybe 55% response rate. And from the structural MRI this time, from the hippocampal integrity, we could predict who was going to respond to talking therapy. The more pristine, the more normal the hippocampus looked, the more likely they were to respond to the talking therapy. So that sort of informs where we might go with this sort of work in the future. Very last slide, just to thank all the sponsors. I tried wherever possible to put the names of all the brilliant people that actually do all this work on the slides as we went. These are all the different people who have sponsored us over the course of time, and I put this one in red because this is very exciting. Joanna is leading a fantastic new consortium working on imaging and vascular dementia into the start of next year. I'm delighted to be part of that and being told by Joanna what I should be doing by when. So thank you very much for listening.
So we did actually start that session a bit late, so we've still got time for a couple of questions, if there's any.
With Arnie. There's one in the front row.
Hi. Is it on? Yes. That was absolutely brilliant. Thanks. I just wondered, my experience of sort of psychiatry, particularly in the NHS outside of academic centres, is that neuroimaging is mostly to say, we think this person has this disease, we just want to make sure they don't have a big meningioma or a glioma or something. How close do you think we are to that paradigm shift in clinical psychiatry, where they will start to accept imaging actually as an adjunct to their sitting down and spending time discussing with the patient and trying different drugs and coming back? And
Yeah. I don't think we'll get there until we can produce something akin to the blood test. You know, as a clinician who's completely comfortable looking at a piece of paper with a blood test saying hemoglobin out of range, iron slightly low and everything. So we probably need to get to that point where alongside the radiological report there's going to be something which basically flags things that are, this hippocampus is pretty small for a 74-year-old female, so query, dementia, do a quick paid associates learning test or do a quick picture naming test or something to see whether we should be looking more seriously at her memory. Or, I think that's where we might go with this. Making the scanners quicker and quieter and quantitative are my 3 Qs I keep going on about, might also help as well. Making them cheaper and more accessible. Somebody was saying, well, we may have them in supermarkets like the salon. I don't think we'll ever go that far, but in the same way that I think in the talks this morning, someone was saying about they're in their 50s and they're starting to think about taking statins. We might be starting to think about other prophylactic interventions, having had a quick MRI scan of the head in years to come as well. The Trojan horse is invariably whether to be the dementia field, but I can see it coming in other areas as well over time.
Any other questions? No? Okay, well, in the interest of time then, I think we will move on, but let's thank Professor Williams once again for a fascinating talk. Thank you for that overview. So our next speaker is Dr. Heather Wally, also known as Heather Sibley. And she currently holds a Royal College of Physicians of Edinburgh GMAS Sim Fellowship and is an Edinburgh Scientific Academic Track Fellow at the University of Edinburgh. Her main area of research interests is in linking neuroimaging techniques to understanding debilitating neuropsychiatric disorders. And she's going to talk to us today about brain and behaviour imaging insights into psychiatric borderlands.
Okay, can you hear me okay? Yeah. Okay, well, thank you very much for that introduction and for the opportunity to come and speak to you today. So I'm going to talk in terms of some of the imaging studies that we've been conducting in psychiatry here in Edinburgh. And I'm going to focus particularly on studies of depression and also studies looking at resilience to depression, so individuals who have the vulnerability markers yet seem to be able to remain well. So just a brief introduction slide about depression. So why are we interested in depression? Well, depression is the leading cause of disability worldwide, and it's a major contributor to the overall global burden of disease. And this was announced earlier this year by the World Health Organization on World Health Day, when it became the leading cause and surpassed other diseases. Over 350 million people globally suffer from depression, and globally depression accounts for 41% of all the years spent living with mental and behavioral disorders. And we really don't know what causes depression. It's likely to be a complex mix of genes and environment, but we really don't know what causes it. And in terms of neuroimaging studies of depression, well, historically, these have been rather less successful than for other major psychiatric disorders, like schizophrenia, for example. And probably at best we can say that we've been consistently inconsistent. And there are 2 main reasons for this. First of all, sample size and lack of power. So the sample sizes that we've been using have generally been too small to give us an acceptable chance to reliably detect signals that we claim that we're able to isolate. And I pulled this graph from a recent publication in Nature Reviews Neuroscience earlier this year. And this is for functional imaging particularly, but I think it illustrates the point. So the median sample sizes that we've been looking at over the past 20 years have really only increased from a median of 10 to a median of 30. So still small sample sizes, lack of power. And this is a further problem for depression, of course, because of the heterogeneity underlying the disorder. So depression is unlikely to be a unitary disorder. There's likely to be lots of common causes which lead to a common symptom of low mood. So the small sample sizes, lack of power and heterogeneity are all leading to these inconsistent findings. So one approach has been led by the Enigma Consortia. So they have conducted meta-analytic approaches. So they've combined data from many different studies who've recruited cases and controls and combined them in a meta-analytic approach to increase sample sizes. So you can see here we have over 1,500 MDD cases and 7,000 controls. And now they're showing reductions in the hippocampus, a relatively small effect size, but with that sample of individuals, we can have confidence in these findings. And more recently, they combined data from 20 studies, which gave us a total of 2,000 MDD cases and almost 8,000 controls. And this study showed that there were reductions in middle temporal gyrus and in medial frontal cortex and in the cingulate cortex. But it's important to remember that these data that are being pooled are all from different studies with different scanners and with different scanning protocols and with different clinical ascertainment criteria. So not only is there disease heterogeneity underlying these studies, but there's also methodological heterogeneity as well. So over in psychiatry, we've taken the view that what we want to do is examine large single study samples of data. And we're currently conducting a large scanning study called Straddle, Stratifying Depression and Resilience Longitudinally, where we hope to acquire over 1,500 scans. And while that data is being acquired, we're also looking at data that's been released through UK Biobank, and that's primarily the results I'm going to talk about a bit later on. We've also taken the approach of combining other different types of biological data in order to begin to start teasing apart the different subgroups that may well exist in depression, and I'm going to give one example of that. And also not just focusing on people who have become ill, but people who have remained well despite undergoing periods of adversity. So I'm going to talk about some of the results that we have, and these are all based on data from UK Biobank. I presume that everybody in the room is familiar with UK Biobank, but for those of you who aren't, this is a study of over 500,000 individuals within the UK, and the plan is to image over 100,000 individuals over the next 5 to 7 years, and they're issuing a rolling release of data. And this data from the current releases is all from a single scanner with consistent recruitment and consistent MDD phenotyping, major depressive disorder phenotyping. And I've just put up some of the modalities here that are available. So there's high-resolution T1 images where you can derive the free surfer volumes that we're all standardly used to using. The diffusion data is available, so you can get measures of FA and MD and some of the NODI variables. And there's also resting fMRI and a task-based fMRI based on emotional faces. So we were interested in using these single study samples to look to see whether we can identify case-control differences. And first of all, we looked at the DTI images. And here we did indeed find lower measures of global white matter integrity. So this is an aggregate measure of FA throughout the brain. So this was lower in cases versus controls. And you can see the sample sizes at the top. This is the first data release where we have over 300 cases and 754 controls. When we go to the next level of detail, separating out the tracks into the different categories, we see that these differences were seen in the association fibres and the thalamic radiations, but not in the projection fibres. And the greatest effects, when we look at the level of the individual tracts, we see the greatest effects in the left superior longitudinal fasciculus, which is shown in red in the top panel here, and in the superior thalamic radiations shown in green in this panel. And interestingly, we also looked at whether individuals had had a single episode or recurrent depression, and we found that the effect sizes were greater in those who'd had recurrent depression, which gives us an extra level of confidence in these findings. I'm just going to also quickly present one of the examples of way we've tried to address issues of stratification. So first of all, we looked to see what evidence there is for biologically based subtypes of major depressive disorder. And we started off with genetic data. And you can see here that there is that depression is on this line here. You can see that there's a strong genetic correlation with bipolar disorder and schizophrenia. And we use this as our starting point. It's also been known for some time that if you separate out depression into age of onset, the early age of onset cases are typically more severe and more recurrent. And there was a recent paper that came out which suggested that these early onset cases, the more severe and more recurrent cases, also have a higher loading of schizophrenia risk variants. So this was all pointing us into the direction of using genetics of schizophrenia to tease apart subtypes. When we look at the neurobiology, we can see that when you contrast early onset and late onset major depressive disorder cases, there are greater decreases in the hippocampus and in the amygdala, and also increases in the lateral ventricles. And one final piece of evidence, so it's been known clinically for some time that severe depression can benefit from augmented treatment with antipsychotics. So that led us to the question of maybe there's a subtype of a major depressive disorder that is actually causally related to schizophrenia. So these are very preliminary results on the first release of the biobank data. And the way we looked to see whether there was a causative subtype is we have modelled interaction effects, so group by genotype interactions. So we modelled group as the MDD status, and we modelled genotype using polygenic risk scores for schizophrenia. So that's like an aggregate measure of how many genes you carry for the disorder based on the effect size. And what we did find was in the MDD cases who had a high polygenic risk for schizophrenia, they showed decreased fractional anisotropy, and that was in comparison to the controls, but also in comparison to the MDD cases who had low polygenic risk score for schizophrenia. And you can see that this was significant in the whole brain, and also the three different tract categories, the association fibres, thalamic radiations, and projection fibres. And at the individual tract level, we see that this was driven by differences in the cingulum, the superior longitudinal fasciculus, and in the anterior thalamic radiation. So finally, I'm just going to talk about some of the imaging studies that we've been conducting on resilience. So here we were interested in whether there are differences in brain anatomy associated with resilience to major depressive type symptoms after the experience of a stressful life event. Now, resilience is one of those things in the literature which is not terribly well defined. So the way that we chose to do it in the UK Biobank cohort, which is primarily based on the data that was also available, is that we've actually looked at the deviation of actual versus expected distress. So just to highlight how we've gone about this. So the number of stressful life events that an individual experiences is on the x-axis, and the level of psychological distress is on the y-axis. And this regression line is just representative of the average of the population. So you can see I've marked out two individuals here who have both had 4 stressful life events. This individual in green here actually has a lower level of psychological distress than the average population, so we've inferred this as having higher resilience. And conversely, the individual who's shown in red has higher levels of psychological distress based on a similar number of life events, so they demonstrate lower resilience. So we've used this and looked at the imaging data, and we found that the individuals, the higher resilience scores correlated with greater volumes of the nucleus accumbens and of the thalamus. And when we look at the DTI data, we found that higher resilience was associated with greater directional microstructure of the thalamic radiations. And I'd just like to point out some of the numbers that we're able to look at now within UK Biobank. So this is getting to almost 5,000 individuals. So with results that we can have confidence in, I think. So just as an overall summary, so we think these are some of the largest single scanner studies of major depressive disorder that have consistent recruitment criteria and consistent phenotyping data. And as I mentioned on the previous slide, we're able now to start looking at over 5,000 individuals. We're seeing case control differences in white matter microstructural integrity, focusing on the association fibers and the thalamic radiations. I've given an example of potential stratifying by cumulative genetic risk loading. And we found resilience was associated with increased thalamic volume and greater microstructural integrity of the thalamic fibers. So I'd just like to finish by putting up my acknowledgement slide. I won't go through everybody on there. This is a slide of some of the individuals who have taken part in the straddle scanning study with their pictures of their brains that they're proudly holding up. Thank you very much.
Thank you very much for that talk. Has anyone got any questions? I've actually got a question to start with. So you'd said that you're interested in having single scanner data.
Yes.
And that different studies obviously have problems with different scanners, protocols, clinical information. Does that rule out analysing data from multi-scanner studies for your work in the future?
No, and it's not just the different scanners. It's also the different ascertainment of the major depressive disorder individuals, which can vary quite a lot. So clinical as well. I think that just adds to the complication.
It's something that we're working on in the DPUK. So obviously we'll be looking at multiple scanner studies as well. Yeah. So. And I was just interested as well about how you model or predict expected distress in these patients.
So that was the actual level of distress that they experienced. So that when they go to the UK Biobank, they fill out a questionnaire, which is a general health questionnaire.
So they actually provide that.
So they provide that data.
I see.
Yeah.
Sorry, any other questions?
Just following on from that, was brilliant, thank you.
Thank
but
you
do they also capture information about when in life they had the stressful events?
So yes, they have 2 time points actually in UK Biobank. They have the time point at recruitment. The ones we used were the time points which was closest to the scan. So that was within 2 years of having a scan.
Because you could imagine with the sample sizes that you're getting now, you can maybe look at windows of vulnerability through life.
Absolutely.
That'd be amazing.
It's very exciting.
Thank you very much.
Yeah.
Hello, that was very good, thank you. I just wondered, you're getting these increasingly large sample sizes up to tens of thousands of individuals, and still, as a radiologist, I kind of drift down towards, when you see these group-wise differences, do you have any feel for how will that filter down to give me a test, so that if I'm looking at someone's imaging with a particular study, that I can say, well, this FA change in this tract might mean that it's this particular risk or disorder?
Yeah. I think the route I see is initially being able to tease apart some of the potential subgroups, and I think that will give us more of a mechanistic understanding, which then might feed through to the clinical work, day-to-day clinical work.
Okay, well, thank you very much for your talk. Let's all thank Heather again for that. And we'll introduce our next speaker, who is Professor Andrew Farrall, and he's an honorary Professor of Neuroimaging and Education at the University of Edinburgh and a consultant neuroradiologist. And his research interests are in imaging investigations of stroke, small vessel disease and the ageing process, but he is now very much focused on education as the Programme Director of the Edinburgh Imaging Academy, and this is the topic of his talk this afternoon.
Great, thank you very much, and good afternoon everyone. I gave a similar lecture on Monday to some of what I'm going to cover today, so those of you that were present on Monday can do a consistency check, and I hope for the rest of you it'll all be new material. I'm going to talk about the Edinburgh Imaging Academy, and I'm the Programme Director of that. And what I'd like you to know by the end of this lecture, this is what we do with all of our teaching and lectures, is have learning objectives. I'd like you to know exactly what the Edinburgh Imaging Academy is. I'd like you to understand why it exists, and then meet those who make it a success, meet our students, and learn a bit about our future plans. So just 5 things I'd like to cover in the next few minutes. This is our website, and I've put it up here because the educational Edinburgh Imaging Academy sits right next to the research, which is one of the important drivers, of course, in Edinburgh Imaging. But the education and teaching supports and underpins so much of the research. And we've heard just in the last talk about the number of scans that are going to get done, over 1,000 scans. You want to do them right. You want to plan for them appropriately. If you have several people, multiple people working on a project, you want them to understand what's going on. You want them to be able to analyze the results. And I think it's very daunting if you enter a research lab or you enter an MSc or a PhD, say from a clinical or from a theoretical point of view, and you don't know much about imaging. It's very difficult to get up to speed. And it's very useful if you have teaching on these subjects that you can refer to and reference. And so that's one reason we exist. If you come from an imaging point of view, you may not know much about the diseases or the problems that you're trying to solve. And so we've also got information in our programs about disease and how you apply imaging to them. And the idea is that if people come and they're working with an Edinburgh Imaging, we have a resource of materials that people from a variety of backgrounds can come to and use to get up to speed and learn about the things where perhaps their previous training or their previous experience leaves them a bit deficient. Now, we basically run our materials in a couple of different ways. We have formal degree programs, and I'll spend quite a bit of the talk talking about that. But everything on the degree programs are also available as short courses. So if you're working within Edinburgh Imaging as a PhD or a fellow, you can just write me an email and we can give you access to the content of the MSCs to help support what you're doing in your research. So I'll focus on the degree programs. We run 2 degree programs currently, Neuroimaging for Research and the Imaging MSc. We also look after some of the PhD applications and support them in their thirst for knowledge. And we also give a lot of our material, we don't give, we have people pay for it from other degree programs because there's such a huge demand for imaging from outside the imaging community, and I'll talk a bit about that as well later. So the MSc in Neuroimaging has been running for 10 years. We've had students for 10 years, but it started in 2004 with an award from the Principal's e-learning fund. And we had £118,000 over 3 years to develop this online MSc. And it's online, it's by distance education, and it's by part-time study. And the very attractive thing about putting it online is that anybody can access it, or anybody should be able to access it, whether they're here or whether they're in some other part of the world. And there are a few reasons why it's quite important for us to get our materials online. There are very few of us in imaging, very few of us radiologists, very few data analysts, and certainly at that time there were fewer than there are now. And so we were being asked in 2004 to give numerous lectures, often the same lecture several times a year to different groups of people. And by putting everything online, we felt then we could direct people just to one resource, and people would have a consistent education, a consistent resource for information, and lecturing time would allow, by freeing up lecturing time, people would be able to get on with their research. We also had several different neuroimaging teaching resources, and this was a good way to try and unify them, again to stop duplication and replication and to bring everything under one roof. And then I've talked about the extending the reach. And we have so many different users of neuroimaging across the campus. What we thought was with a modular approach, which online allows you to do, you could create bespoke packages of teaching for different groups of people. So if someone's interested in stroke, they could do the stroke package. Or if someone's in psychiatry and interested in schizophrenia, they could do the schizophrenia package. And so that is feasible. And if, again, you would like to know more, get access to these materials, please contact me. The sort of larger goals, or the wider goals, were to contribute to the understanding of neuroimaging to people from a wide range of backgrounds. And we've had people from all these different backgrounds on our programs. And so you can see that trying to sort of design something that takes so many different people and brings them to one point is quite challenging. the final point on this slide comes back to what I started off with. Imaging is expensive. If you're trying to do big studies and you're sort of starting from a point where perhaps you don't understand too much about imaging, hopefully by the time people have done our MSc, they will be able to design and improve the quality and the interpretation of various neuroimaging studies done in research. The initial format of the program was to have 8 taught courses, which students do and still do over 2 years. The courses consist of several individual modules, and the final year is a project year, and these are the basic courses. So we have something very focused on techniques and physics. It's not at a medical physics level, but it's not far off, and I think our students find it the most difficult course. And then married to it is the applications and disease course. So once people have learned about the techniques, they learn about how certainly we in Edinburgh Imaging apply these techniques to the various diseases we're interested in. The practicalities course is very commonly taken in and of itself by people out with the program. It talks about things you need to know about MRI scans. Can you put people in with a pacemaker or not? A lot of people sort of enter imaging labs without those sorts of basic bits of knowledge. So it's a very useful course for people who are encountering radiation or MRI for the first time. When trying to analyze and interpret scans, there's a number of different approaches. There's image processing, and we have so many different processing techniques. We have two courses which cover them. We have a study design course which approaches imaging study design. So calculating how many patients you need, say, for an MRI study to be analysed and get a significant result. We have a statistics course as well, which addresses study numbers, patient numbers, and processing data, both measurements, for example, or questionnaires about what people find on imaging. And of course, we have neuroanatomy, because if you don't know where things are happening, then it's very difficult to analyze an image. And then a few years later, we added 3 extra courses: a functional imaging course, an image analysis course, and translational imaging and clinical trials. And these are electives which sit beside the common imaging process techniques 1 course. And I must say, functional imaging and the translational imaging courses are by far and away the most popular electives. And I think that reflects research interests worldwide, really. So a bit about online learning. Again, we started with a small number of people with a lot of lectures, but it's not just putting the lectures online. This is the environment that all of our lectures sit within. It's the Learn environment, which is supported by the university. And you have a series of sort of options here on the side. You have a welcoming page. But the core of all of our courses are individual modules which last a week or 2, all supported by tutors who are present online to answer questions and to help guide any discussions. And if you open up one of these modules, you may have 1 or more lectures, and the lectures run online. You can print off the lecture in a PDF file, and you can also download the audio. One of the things I hadn't sort of anticipated, we did this for accessibility, so people would be able to listen if they were visually impaired, and we do have people who are visually impaired taking our imaging program. We had the PDFs, because a lot of our students don't have English as a first language, and we felt they should be able to read along as they go along. But of course what's happened is people download the audio and listen to it in their car on the way to work, and it's like having a sort of teaching session while they're in the car. And the PDFs, several of our students have said, well, basically they now have a textbook of imaging printed off. We've sort of got this interactive and enhanced textbook of imaging. And they also make notes on the PDFs, of course, as they go. And what students appreciate is having these different ways of absorbing information and interacting with our materials, which we hadn't anticipated when we set off. So each lecture has several slides. You can read the voiceover. They all have voiceovers, so that people can just listen along and make notes as they go. And there's discussion boards which are tutored. And if a student has a question, what's very nice is often other students will answer the question, and the tutor just has to make sure discussion stays on track. So there's, even though people are placed around the world, they do have a sense of belonging to a class and having classmates. Social media has been interesting, because that's really sort of taken off since we started the program. And this year, for the first time, we had a group of students who are in Mexico and the States and in the UK and in Australia form a WhatsApp group and chat about stuff online, and they've all arranged to meet up sometime about the time they graduate. They're really keen to meet each other in person, and 2 have visited me in the past couple of months. Online learning doesn't work unless you engage students, so every course has got an activity. And we also have final assessments. When we started, we didn't have these, and students left the study until the last minute. Some things don't change, whether you're online or in a classroom. But by having activities with regular deadlines, you force the students to engage, and you force them to study, I guess. Again, it's not just a PowerPoint presentation. If people produce material for us, and there are 20 different authors contributing in the first instance, we don't just need a PowerPoint, we need a voiceover, we need multiple choice questions. Students love multiple choice questions, they get immediate feedback. We need to be able to run final assessments, and the activities need careful design, and they can be in the form of debates or journal clubs. There are several different types of activities people can do. You also then need to tutor, so some of the tutors were also authors, but others weren't. And you need people to monitor discussion boards. These students are very highly motivated and have often very detailed questions, so you do need quite a level of expertise. And I think the feedback I get from my tutors is they learn a lot from our students because they're forced to go look up the answers and to explore the answers to the questions themselves. And of course, final assessments need marking, and we need to provide feedback. And then we need to administrate the program. We need people who can manage the authors, manage the tutors, manage the students, and interact with the college and other university administrative systems. So this is some feedback we got from this year, the graduates who left this year and also a few years ago. Basically, time is needed to go through lectures because sometimes they are very difficult. In fact, neuroimaging is anything but easy. And so we have a lot of people who are interested in the program, my personal opinion is they think, oh, this will be an easy degree. This will be something that's a bit easier than sitting in a classroom, and I can do it online whenever and how I want. And that's not the case. This is quite a rigorous degree, and it is a very detailed degree, which requires a lot of attention. And the top advice tip we get from all of our graduates is to set aside regular study times each and every week. And it usually takes the first 6 weeks of techniques and physics for them to realize that. And then they're fine once they've come to grips with that. The feedback at the top here is from one of our first graduates from Neuroimaging, which I'll let you read. The key point I posted is for this last reason. I really appreciated being able to do the coursework from home, especially as I became a mum 2 months after the program started. And this woman disappeared from the activity for a couple of weeks and then came back and said, I'm so sorry I haven't contributed. I just had a baby, but I'm back. And she's the first of 5 who have done this, had babies and just continued without a blip. So we have a very different student group, say, from people who enter an MSc straight after a BSc. These are other comments that we've had from graduates here. The program does seem to satisfy a need in people who engage. So after 5 years, we had 13 MScs, a diploma, and 6 certificates. And at the same time, Edinburgh Imaging and the basis of Edinburgh Imaging was growing. And so we were able actually to apply for another grant to expand our teaching. And we now have a general imaging MSc, so we go beyond neuroimaging. And we've added these courses here: clinical applications, image interpretation and evaluation, biomechanics, preclinical imaging, microscopy, body anatomy, and cardiovascular imaging. And as of this academic year, we've now graduated 41 MScs and 19 certs and 6 diplomas. And these are the numbers of students we had on both programs in the last year. The interesting thing to me about this distribution is we have really students who are quite keen to commit to the full study. But we have a significant number that just want aspects of what we teach. And so they just want to take certain courses, and image analysis and processing is one of the big ones. They only want those courses, and they want to exit with a certificate in those. And so future development, I think, needs to be driven a bit by that recognition. I've not got too much time. I'm over time now, but we basically have had 360 applicants. I'll whiz through this very quickly, half of whom are doctors, and only 25% of those are actually from radiology. So again, this speaks to the variation and the backgrounds of people wanting to do imaging. Unfortunately, 40% never then go on to enroll, and 20% withdraw. So we're just left, we've only had 150 students over the past 10 years, which is administratively challenging. And it changes the distribution a little bit. We end up with 60% doctors. And I think most people back out, in part because of cost, and also because they don't quite realize when they first register what online learning involves. And it does shift the fraction who are from radiology slightly. it's really medical doctors who back out the most. You can see there the proportions drop down to 20%. Also quite interesting to me is that of the people who finally do take the course, this is the female to male split, 52% women and 48% men. The age is not really different, but it's important. They're over 30. These are often professionals. They've often been working for several years, and they've come to us because they realize there's a need. They want to change a direction in their careers, or they've been promoted and need to know more about certain imaging aspects, and that's usually what brings them to us. Where do they come from? These are where our applicants come from. Only 35% from the UK and Ireland. We get 15% from Africa, 15% from Asia. But let me show you the next slide here, because when we actually look at the students who go on course, the percentage of change, half end up being from the UK, and we see a huge drop from the African applicants and a drop of a third from the Asian. And in fact, if you pick this apart as well, about a third are from the EU and Asia. They're actually living in the UK, but they are actually from these other countries. And one of the things they say is that they can only afford to do the MSc because they're earning UK salaries. They couldn't do it if they were living at home. So there's sort of subtleties we need to pick apart about who we pitch this to and who can do our materials. So I think I've spoken about all of that there. But once you go online, everybody wants a bit of you. These are all the other groups that we offer our materials to, whether it's a 10 or 20 credit course or bits of modules. So in addition to our 92 students, we have another 234. We had another 234 last year who were taking materials housed by us. Lessons I've learned from e-learning, well, there is a huge demand, and online methods really are the only way that we could have this reach. It's the only way that people could access our materials. They are labor intensive, both for the students and for the people running the program, but it's a bit different from face-to-face teaching, and the university, I think, is still learning how to get that balance right. The online content certainly does not run itself. You need a team to do all sorts of work in the background, which I've spoken about before. In terms of our students, online methods work well for those who work full-time. Almost all of our students work full-time. Very few are part-time or taking time out from their careers. But it does allow them to balance learning around other life events, like having babies, like having a death in the family, like having very heavy on-call if they're medics. They don't work so well for on-campus students. We've been asked to, in fact, we gave our online teaching to 60 students in the past year who are on campus. And really, students on campus expect face-to-face teaching, and so they complain if you just go completely online, and you need more engagement. And again, that's a bit of a challenge that we're trying to deal with. Online students, as I said, are over 30. They're mature, and they do expect mature and flexible interactions with the university. And the problem is, if you don't do online properly, you get a very bad reputation. So it has to be done well to work. This is the team that runs the office. Not everybody wanted their photos shown, but it's a big team, and it's the only way you can make things work. And these are the people who have contributed over the years to tutoring and creating content. So thank you very much for your attention.
So yeah, thanks for giving us an overview of the Edinburgh Imaging Academy. A fantastic resource, and presumably it's like never really finished, that there's lots of scope to continue to grow. And
yes, I could go through a few more slides, but we have 8 courses that we're hoping to launch over the next year,
okay,
and maybe another 8 the year after that.
Fantastic. Any other questions? If not, as we're already kind of slightly running behind, and I'm sure you all need a coffee, we will move on to our last speaker, who is Dr. Jerry Thompson, Senior Lecturer in Radiology here in Edinburgh, and he will give a brief update on a PhD networking event.
I'm going to use the old school handheld. So I'll be very brief here, just I know we've got coffee waiting to get out. We've heard a lot of exciting and interesting talks today, and then Professor Farrell's spoken to us about the training people and educating them to become researchers and be involved in neuroimaging. And this is about an event that speaks to both of those, about the researchers that are up and coming just now. The Edinburgh Imaging Expo, that this year, 2017, it'll be on the 25th of October, so save the date, and it's primarily University of Edinburgh, but it's an Edinburgh-wide initiative, so we have people contributing from Heriot Watt also. and it's really aimed at postgraduate students across Edinburgh who have some form of imaging in their research. And it's a bit like a mini conference. People will get the opportunity to synthesise the research into an abstract, submit it. It will be assessed by a panel of judges and luminaries selected for oral and poster presentations. Come and present the work in a reasonably welcoming forum that's quite relaxed. You can get cross-pollination, questions coming from the audience, tips, collaborations that you may not otherwise have expected across the different institutions. And we do this year have actually fantastic prizes that will come out next month with the finer details of the event. But it really is worthwhile. PIs out there, encourage your students, get them to think about getting their work into some sort of semblance of order now to present at this time. The students who are out there, really give some thought to this and tell your friends about it. It's part of just the wider Edinburgh Imaging Initiative. If you want to contact us about anything, then you can see email address edinburgh.imaging@ed.ac.uk, and we'll leave it at that, but save that date. Everyone is welcome to attend, and it's a very interesting and challenging meeting, and it's good for practice and good to get exposure to the kind of research that we're doing here. So I'll let you go on and get some coffee.
Yes, thanks. I just want to thank all the speakers from this afternoon's session. That was great. And for the speakers for the next session, if you still got to put your talks on, please come down and see Michael. Thank you.